Healthcare Now Radio's Interviews Now. Thank you for joining us. I'm Shereese Maynard, today's host. Follow our show using the hashtag Interviews Now and join the conversation. In this fast-paced, ever-changing landscape we call healthcare delivery, who can we trust to tell us, good or bad, what's happening now? Let us help you sort out these issues with today's thought leaders in the know. On this episode, we will be discussing current issues affecting providers, payers, and beneficiaries with Andria Jacobs, COO from PCG Software. Andria, thank you so much for joining us.
Well, thank you so much for inviting me, Shereese.
So tell me a little bit about your background. And I'm very familiar with PCG. I always think about operational efficiency when I think of your company. But tell us a little bit about yourself and how you found yourself in the healthcare space.
Well, I'm a nurse, and I've been a nurse almost 50 years. So time passes quickly in healthcare because there's so many things changing all the time. And I started out, I did 20 years of clinical work in the ICUs and emergency department. And then I got hit by a doctor and broke my neck, and I had to change careers. So I went back to graduate school, and I have a master's in hospital and healthcare administration. And I did research at UCLA and did consulting for large hospital organizations for the most part through an accounting firm. And about 20 years ago, I went to work for UniHealth America, and they owned Pacific Care and Care America, and were a fully integrated healthcare delivery system. And that was my first introduction to healthcare related to claims information. And one of the products that UniHealth purchased was Virtual Examiner, and I used Virtual Examiner, and then when they sold off all of the entities, I went to work for PCG Software. And, my goal was, I can't really lift patients at this age anymore. And so my goal was to go out and take care of patients' money, because premium dollars are really important when either you or your employer or the federal government are paying for your premium. And what we find is that healthcare bills are one of the greatest causes of bankruptcy in this country. So we feel it's an important mission to save money for both the patient, the payer, and to pay the provider fairly.
Wow. So was the transition into health IT pretty comfortable for you?
Well, it was sort of an interesting transition because I still think, that I'm the technology dummy in the company, but I started out to be an engineer. So a long time ago at Purdue, before I switched to nursing, I had, beginning courses in software, and, I learned Fortran and other languages which are no longer supported anymore. But, it's the same kind of thought process. And my responsibilities in the company are really focused on determinations and what kind of reasons we would either pend or deny a claim that's coming in to be evaluated through the software. And, we apply 45 million edits to every claim line that comes in, and those are all date-based. So my job is really to scour with the staff through the CMS and AMA and other federal and state program materials for things that should not or be paid or should be pended for review by either a clinician or a claims auditor.
Well, that's certainly a worthy goal. PCG Software has been developing software for 35 years with a mission of reducing cost of healthcare. A lot has happened in healthcare over those 3 decades. Can you tell us a little more about the markets you're serving now and how today's software is supporting the mission?
A lot has changed in 35 years. It is just amazing because, of course, regulation and rules and laws all change all the time. We support clients, really a variety of clients. So it could be anybody who pays a healthcare claim. It could be a union ERISA plan. It could be a managed care Medicare plan. It could be a managed care Medicaid plan, or an IPA or an MSO, who are all involved in healthcare delivery and claims payment. We have clients all over the country from Puerto Rico to the West Coast. And of course, they're segregated in some ways just by the areas where there's the highest penetration of fraud, abuse, and waste. And we've seen, a progression in the amount of fraud, abuse, and waste over those 35 years because it's so profitable. Our software, we update it at least quarterly and sometimes on a daily basis based on, something new that comes out September 15th from CMS saying we're going to pay this way now. Our clients all have timeliness requirements in paying claims, and we want them to be consistent and accurate because there's nothing that irritates providers more than not having their claims paid correctly. And
Yeah.
And one of the things that we try to do is to make sure that physicians are paid, accurately, and that is something that they can sort of avoid having more headaches from the payer. The other thing is that when claims aren't paid accurately by the health plan or whoever is delegated to pay those claims, what happens is it increases the cost for the patient. The patient may have a deductible. They may have a total out of pocket. There may be different kinds of benefit buckets that can be affected by the claim being paid incorrectly. And so we want to make sure that not only is the physician made whole and his claim paid right, but also that the patient doesn't incur charges that they shouldn't have to pay.
That's absolutely right. Claims denials are, I like to say the age of a claim is always a problem for providers. So claims denials have always had a measurable and negative financial impact on the bottom line for medical practices. What can software vendors like PCG and others do to help billers ensure coding accuracy for claims, thereby reducing rejected claims and improving billing accuracy?
Well, for one of my jobs that I had in the past was running billing for a large internal medicine practice on the west side of Los Angeles. And one of my claims to fame was that I never got a claim rejected because I made sure that we billed correctly, but also that the doctors had documentation to support the actual claim that went out. And, it costs, $25 to $45 for the practice to rebill. And that means if one claim line is denied, somebody has to go back and pull the record, find out what's wrong, research it to see if there's the wrong code, the wrong modifier, the wrong diagnosis, look up a source document, send in the appeal, and make sure that they paid this correctly. And then send all that documentation in, and then wait for that money to come back in. So there's the opportunity cost that affects the provider's bottom line. So what we do is not only do we have products for the payer, but we have products for the billers so that the billers are paid correctly. And that billing can be used through tools that we have that look at the codes that are submitted, the ICD-9 or 10 codes that are being submitted to support the procedure codes, and write diagnosis, and then write modifiers and write rules. And that makes sure that they have a defensible position, because all of our edits and all of the information that go out to our client is really based on the AMA, CMS, or another regulatory body. We don't make up any rules ourselves. We interpret them, and sometimes we have to call CMS or Region 9 or one of the MACs to find out really what they meant. But we try to be true to the intent and the rules set up by the federal and state governments.
So in other words, the cost of denials is a focus you guys have.
It is a focus because, physicians are struggling to make ends meet. Some health plan contracts hardly cover the cost of care. And we see that, medicine, it used to be really hard to get into a residency program, to get into medical school, and fewer people are really looking at medicine as a career because it is very expensive to become a doctor. And then there are all these people trying to reduce the amount that you're getting paid. And that is a critical problem as all of America is aging and more babies are being born without having enough physicians. There are a lot of counties in Texas that have no physician in the county at all. And I think that we're going to see more of that as time goes forward, unless there's some kind of financial sort of reckoning where physicians actually get paid for the cost of providing care.
And that's actually a scary reality. You know, when you think about people aging, we need more physicians. And the latest data tells us that by 2020, we're going to have a bad problem. But by 2025, we're really going to have a severe shortage of doctors. So, yeah, that claims an eye on what it's costing to our physicians is a serious issue. One of the other ways to help reduce healthcare costs in this country is to keep patients better informed about the scope of their care, not only clinically, but also on the financial side. Now, for some patient populations, understanding EOBs remains a challenge, forcing many to keep blind faith in their providers. How can providers help to better educate patients on their financial responsibilities?
Well, I think that everybody who receives a copy of the explanations of payment and benefits from their insurance company needs to be able to read that document. You know, many health plans, managed care plans, don't even send to the patients or members an explanation of benefits or a copy of the remittance advice that's sent to the physician or other providers. So if the patient doesn't have any financial responsibility, or it's just a small amount due for them to pay, most patients, what they do is they either file that EOB or they put it in the trash. They don't even attempt to look at it. And, you know, some providers will tell patients not to worry that their insurance will cover the bill. But in those cases, it's really easy for somebody to put things on that bill that are not really legitimate charges. Patients don't always realize that the premium that they pay or their employer or the government pays on their behalf is tied to utilization and cost. There's really no such thing as a free lunch. It's nice not to have to pay for your premium, but it's a responsibility to still make sure that the things that you received are billed, but the things that you didn't receive aren't billed for. And, you know, one of the challenges is to try and where do you start teaching people to be responsible financially? Really, it has to be when they're young adults, when they're in high school and college, and after, you know, because all of a sudden they're going to be married and have kids and they're going to be having insurance bills and things come in. They need to be able to understand what that means. And, you know, families, when financial decisions are being made about healthcare services and stuff, it's a good time at dinner to sit down and talk to your kids about, you know, you went to the doctor today and our copay was $45. And tell kids what does the copay mean? You know, why do we pay that? You know, what is our share of cost? So I think that these, you know, we need to maybe have some of this in finance in schools, but also it has to be a family kind of value.
That would be an excellent dinner discussion for families to have, you know, explaining to their kids from an early age what those costs are as they go through high school and learn different things about healthcare and getting care for themselves.
Right.
Okay. So one of the challenges in healthcare is related to observation status designation, which has been used in the past by hospitals when billing Medicare. There was a recent class action lawsuit, which I'm actually sure a lot of people don't know about, but I actually know a lot about this case, and it's very fascinating. The lawsuit against the government on behalf of Medicaid beneficiaries, it's an interesting one. Can you tell us a little bit more about Alexander v. Price, and can you elaborate on the negative effect observation status can have on seniors?
Well, I think that this is one of the most egregious cases that I've read about in a long time. And it's so interesting because 84-year-old Nancy Nemi of North Carolina was hospitalized in an observation status for 39 days earlier in 2017. And she was in the emergency room originally, and it took weeks to stabilize her blood pressure, and she had complications. She was categorized as an outpatient on observation status for her entire hospitalization of 39 days. Now, patients don't know they're on observation. They're in a regular bed. They're in, nurses are coming in to take care of them. And they don't realize that the financial implications are different between being inpatient and outpatient. And therefore, when she was done with her 39 days of outpatient care, she was to be referred to a skilled nursing facility for subsequent care. And what happened was, because she had not had a 3-day inpatient stay that Medicare requires for her having coverage for her skilled nursing facility care, she was stuck with a big bill. Now, her son tried to fight this. And the problem is that there's really no great appeals process for appealing on an expedited basis a observation stay. And so what's happening to these seniors is they think they've been in the hospital 3 days. They've been laying in a hospital bed, and somebody's been taking care of them, and they get transferred to the skilled nursing facility. And the first thing they find out is, gee, this was an observation stay. It wasn't an inpatient stay, and you're financially responsible for the full charges for staying in that bed. And, we're seeing more and more patients move to an observation stay because it saves money for the federal government. And that's a good thing to save money, but it's not when the benefits haven't been sort of managed so that moving them to observation and having them in observation should not eliminate their ability to go to a skilled nursing facility.
If you're just tuning in, you're listening to Interviews Now on Healthcare Now Radio. I'm talking to Andria Jacobs, COO from PCG Software. So let's continue. Another topic that needs to be addressed concerns the increasing incidence of medical ID theft in this country. What are the ramifications for healthcare providers, and what are some of the ways they could do better to protect themselves from this form of fraud?
Boy, that is a tough question, because what we're seeing is that medical identity theft can be harder to discover than other types of ID theft, because it happens when somebody steals your identity and then obtains medical services, and you may not find out about it for a while, especially if you're not paying attention to those explanation of benefit forms that come in from the health plan when they pay claims on your behalf. I think that more than 27% of the data breaches in 2017 were medical or healthcare related, according to the Identity Theft Resource Center, which has a great website on identity theft. So for providers, I worked in the emergency room. You have all these people showing up for care. And I think you have to have a high index of suspicion. So when the information doesn't match, when their ID on their driver's license and their picture on their driver's license doesn't match their credit card information or the name on their medical identification card, or their address is an empty lot, or they have no photo ID, then you should start thinking that this may be a case of medical identity theft. It's really important to catch this, because all of a sudden wrong information shows up in your medical record, and that medical record may be shared with different providers. So things have happened where people came in and they had originally a type AB negative blood type, and then all of a sudden somebody sees in there they're really an O positive. Well, the O positive wasn't them. If you find out that you've had medical identity theft, you really need to report this as soon as possible, both to the insurer, to the provider, and to law enforcement, because this can be grant theft, because we see people using medical identification for hospital stays where you can see $20,000 to $30,000 of incurred charges in no time at all. The other thing is that you need to report a bill for medical services that you did not receive. That is, something that should trigger real concern on the part of the beneficiary. And then things that also can help you identify that something is going on is that you get calls from a debt collector about a medical debt that you don't owe. And, you can let the collector know, but their job is to collect bills. They don't care if it's the wrong person, particularly. Right. And you need to make sure that you're letting, both your credit reporting agencies, any kind of fraud protection services, and again, the insurer, the provider, and law enforcement that there's a problem. The explanation of benefits can also say things like you've reached your benefit limit. So maybe you have a limit on the amount of physical therapy that you can have visits. And all of a sudden you haven't had any physical therapy this year, and we see that, you've had 25 physical therapy visits and you don't have any more without a review and medical necessity requirements. And when that happens, that should also trigger some real questions. And then, of course, if you're a doctor and you see your medical record and you see that there's conditions that you don't have indicated in that record, then you want to get that fixed right away, because in an emergency where you're in an integrated healthcare system where there's shared medical information, you don't want the emergency department or surgery or somebody else making decisions based on somebody else's information.
Right. And it can be really hard for individuals to recover, and it can devastate you. So you mentioned a website that people can go on to report, or can beneficiaries go on that same site, or is it just for providers?
It's anybody, and they just go to the Identity Theft Resource Center. They can Google that, or search on their browser for Identity Theft Resource Center, and their really excellent information comes right up.
That's good information.
Yeah.
Okay, so fraud also occurs on the provider side. I know a little bit about that, as well as some rogue doctors intent on committing corporate fraud. What is being done at the federal level to help protect not only individual patients, but also to mitigate the skyrocketing cost of healthcare on a macro level?
Well, the good news is that the federal government is working really hard to preserve healthcare dollars and to stop fraud, waste, and abuse. For every dollar the federal government spends on combating healthcare fraud and abuse in the last 3 years, they've recovered $4. And that's a moneymaker in the government for me. I think that's good. Last year, the healthcare fraud investigations by the Health and Human Services Department and the Department of Justice recouped $2.6 billion. And while that's not their record, it's still a healthy amount of money coming back into the federal government. Last summer, and I think in June, the National Healthcare Fraud sort of task force took down 601 individuals responsible for over $2 billion in fraud losses. And that included HHS, the Office of the Inspector General, the Department of Justice, the FBI, and used frequently, they bring in then the state Medicaid fraud control units, state attorney generals, and county district attorneys, and local police. This is a big deal when this goes down. And this was, I think, the largest healthcare fraud enforcement action in the Department of Justice's history. And out of these 601, 76 of these were doctors charged for, and 84 opioid cases involving more than 13 million illegal doses of opioids. And, 72,000 people died the previous year from opiate overdoses. And it's a serious problem. That's more than the total amount of people that died in the Vietnam War. And it's twice as many died in traffic accidents, and they're young people frequently. So we're losing, a population of people who should be growing old, and their lives are cut off early because they received, illegal dosages of drugs from physicians who are not supposed to do any harm. So, when I look at those kind of things, I see that the government is really working hard at, stopping fraud and abuse and trying to control this. We also see that now, healthcare is such big dollars that, the Coalition Against Insurance Fraud, who I call the Coalition, there's been an increase in the organized transnational crime rings using insurance fraud as a vehicle to fund both illegal activities and terrorist activities. And it appears that the terrorists are really capitalizing on this because what do we do to people who do insurance fraud? They get to go to a federal or state prison. Nobody shoots you. No one cuts your feet off. And so when we look at this, that it is millions and millions of dollars being used to fund illegal activities. And people are scared to report them. I don't want to report MS-13 for insurance fraud. It's a dangerous occupation.
And I think it's also, important to note that even unintentional fraud is still fraud. The government doesn't recognize what you put something in the wrong column or the wrong day and that type of thing. So what you mentioned here is totally true, but I think doc providers probably need to, educate themselves and be better educated about fraud.
We do a lot of training on fraud. Part of our software package is a module that provides profiling, behavior profiling of how providers bill, so that the network people for these health plans or for a physician group can go out and really work with the physicians. The goal is not to put physicians in jail, but to educate their offices. And because this is like paying your own taxes, as far as I'm concerned, it's really difficult to do billing. I mean, we're paying billers in the 70,000s because this requires extensive training. It's really hard to do, and there's so much dependent upon it. And careless disregard of the truth of the matter can get you a False Claims Act in a minute. So, we want physicians to be really aware that that attestation that they sign on the bottom of the claim saying that everything is truthful and real is really understood by their entire staff, that if lies on these claims can send you to jail.
That's a good point, educating the entire staff. This has been very fascinating for me. Your insights are amazing. I actually just want to thank you for coming on today.
Shereese, it's been really a pleasure to talk to you. You know a lot about this, and it makes it a lot easier for me to participate in the discussion.
Yeah, we could probably talk shop for hours. When I looked at the denials and the claims, it just brought back some memories for me trying to educate physicians on that very topic. So I thank you for joining us today. If you're listening, we were joined by guest Andria Jacobs, COO from PCG Software. To learn more about PCG Software, find them on Twitter at PCG Software. Thank you for tuning in today. For more information about Interviews Now, visit our show's program page on healthcarenowradio.com. And until next time, if it's happening in healthcare and it's now, it's on Interviews Now.